Good evening, friends. Welcome to 143rd webinar. Dr. Sonam will be arriving soon. I want to give a message to all of you. Some doctors have approached me to take a lecture on common problems faced in practice, like a patient comes to you with cold, no fever, no sneezing, only congested nose, and he has to drive now 120 kilometers, so you possibly cannot give any antihistaminic. Somebody has pure running nose, nothing else. So how to prescribe in that? Now, to take a webinar on that, I will require at least 30 to 40 queries. So if you have similar queries, please share with Preeti. And once I have enough queries, I will plan a program on that. So Dr. Sonam has just joined us. Dr. Sonam, I welcome you. And I am very pleased to announce that your last webinar attendance was 200, but on the next day, 300 plus people viewed the video, and still many more are viewing.
Excellent. Thank you. I think
that shows about the clarity of talk that you delivered. And we are really thankful to you for joining us.
Thank you. Sorry for the delay today.
Not at all, ma'am. We are all practicing and I know emergencies.
Right.
So, although everyone knows her, just repeating, that is a consultant and interventional pulmonologist, MBBS, DNB in pulmonary medicine, PDDM, Hermes, a European diploma, and has been an observer in interventional pulmonology at Rajiv Gandhi Cancer Institute and Research Center, New Delhi. Dr. Sonam is attached to multiple hospitals, Safi, Reliance, to name the two. Dr. Sonam, over to you for this very challenging talk on tuberculosis diagnosis.
Right.
Please take over.
Thank you. Good evening, everyone. And a little bit of pressure after the last talk, and I hope I am able to do justice to what we are going to discuss today, because tuberculosis is something none of us can escape. It doesn't matter which specialty we are from. It's not just related to my field because I'm a TB specialist. It's all around us. As a nation, we have an aim. It's just 2 years away from here, and I don't know how we'll reach that. So it is the need of the hour for everyone to be aligned, whether it's a family physician, whether it's a gynecologist, doing a laparoscopy and realizing, oh, there are tubercle studs, what to do with the samples, when not to miss it, because it's no longer that it is just TB. TB hai, to which type of TB, what samples should I send, drug sensitive, drug resistance, it doesn't stop there, whether it is monodrug resistant, polydrug resistant, MDR TB, XDR TB, so on and so forth. And we in Mumbai, really, when you speak with tuberculosis experts throughout the country, you will, they say, oh, Mumbai is a complete country in itself when it comes to TB. They don't, in rural, jokingly, someone from Kerala met me and, they were like, in our hospital, if a staff nurse has TB, the first thing they ask is that, has the staff been working in Mumbai? If she's working in Mumbai, their thought process changes, because the sort of microbiological diagnosis that they have to do to accurately diagnose this is completely different from someone who may have picked it up in the rural setup. And that is why the diagnostics that we subject our patients to, microbiological diagnostics, is so extensive at the start of treatment. We don't, in Mumbai, no longer start TB treatment and then see, oh, the patient is not doing well. Now send the sputum for culture. Now see whether it is MDR or not. No, we have been increasingly seeing primary MDR, someone who has not had TB in the past, but first time developing TB, not necessary from a lower socioeconomic strata, office going people, well-to-do people, coming with a lesion which is suspected of TB. And when we do the test, we realize that this is MDR. And that is scary. It used to be 2%. It's come up to almost 10% in certain parts of Mumbai when you see the way it is reported. So I think I have kept very limited slides. I have kept more time for discussion this time, but there are important things that I want to say, send across, and then we will take actual questions from people if they have, so that we all get some practical information from here. With this, I will start my discussion. I hope my laser pointer is seen, right? So what we know about tuberculosis, we know that it has been with us for ages as a human race. There have been, and you must have heard this many times, there have been multiple reports of the mummies in Egypt also having tuberculosis, right? So the some tuberculosis focus found in samples from mummies. There is a difference between infection and disease. If we all are to look at, our Mantoux, none of us have symptoms. Assume 100 of us doctors have no symptoms, and we do our Mantoux test. It may turn out to be positive. All it means is that our body has been exposed to the tubercular bacillus. So we've been infected. But do we have TB? Do we need to start TB treatment? No, we do not have the disease. Unfortunately, with tuberculosis, once infected, always infected. So the development of the disease depends on the host and the environmental factor. 10% of the individual amongst us who have normal immunity, no comorbidities, there is a 10% chance that they will develop tuberculosis in their lifetime. And this will increase. If there is an HIV patient, they will have a 50% lifetime risk of developing tuberculosis and a 30% lifetime risk of developing tuberculosis for a diabetic patient. And I don't, at general practitioners, I am sure you all deal with this more than I do, where diabetes, India is another hub and endemic country for diabetes and its related complications. So we have our hands full when it comes to tuberculosis. Now, I was just pondering upon, before going to challenges in diagnosis, what sort of diagnosis? So I could think of three things. There is clinical diagnosis, there is radiological diagnosis, and there's microbiological diagnosis. And I have very recently, I have come across this case which highlights all these challenges step by step. And that's how I will start my discussion. The case is Mr. XYZ. He's a 70-year-old male, non-smoker. His office was next to a woodcutting workshop. And he has a chronic cough. And he walked in and he's like, hey, listen, doc, I know that my cough is because of this, some sort of allergy. My lungs are damaged because my office was next to a woodcutting shop. And I have been evaluated thoroughly by a specialist. And that is my baseline. Every day I change 3 napkins because that much expectoration comes. And so with this history, I thought, of course, yeah, this person may be like an old TB sequelae or a bronchiectasis patient, and or an ILD patient, and he's been wrongly labeled because we do get such patients also. He had a past history of tuberculosis, no details available, patients not sure. And eventually I realized that this is bilateral bronchiectasis that we have. And he had that since childhood. When I say childhood, he meant his adolescence age. And his wife was like, yes, even when I got married, before we had children, he had this cough and expectorations every time. So the main complaint was that first thing was that he had hyponatremia. He had a symptomatic hyponatremia, because of which he got evaluated, because of which then they thought that, no, let's get the lung evaluated, because other than a chronic infection, they were not finding any cause. He felt feverish, never documented temperature. He had a cough. Again, we didn't know how much to make of this cough because the cough has been there since years. And a weight loss of 2 kgs over 3 to 4 months. Again, he did not have an accurate measurement. Skinny, built man. Because chronic cough, when you have bronchiectasis patient, they have a lot of expectoration. They lose a lot of protein. So if they are not well compensated with a high protein diet, it becomes, we do see that there's a lot of sarcopenia, etc. with these patients. He was taking an inhaler regularly, religiously, and he had learned how to manage his exacerbation. When he felt worse, he would take the nebulization. And this prescription was given to him by someone 7 years ago, and he's been following that. Lung function, all that, never, I mean, once he's like, he had done it, and he's like, I have so many CT scans, I cannot get all of them. You just tell me what reports you need, and then only I will get it. This was this gentleman's x-ray, and he's like, you can't really make out. And he was so well educated about his own disease, and he's like, there's nothing that we can do with an x-ray. Mera x-ray aise hi aata hai, is exactly what he says. And we can see this. You have cystic lesion, a few air fluid levels, more in the lower lobes and then the upper lobes. Now, the theoretical next step, is whether I do imaging, whether I do blood tests. So recurrent exacerbation, my thought was that, has he developed diabetes now and he's not aware, which is why he's having these symptoms. Triple H, unlikely, but still as a part of our protocol, it comes to mind, vitamin D level, etc. Do I do a MAN2 test, whether this symptom of weight loss is significant? Do I do an IGRA test, which is a blood test which gives us information about latent infection, TB infection, not necessarily active TB, just TB infection. So it's the new age MAN2 test. And whether I send sputum, and now whether the sputum should be AFB smear, gene expert, AFB culture, MGIT, routine culture, line probe assay, first line, second line, whole genome sequencing, or pyrosequencing. So this is the diagnostic dilemma that comes to us. One, my dilemma was whether this is even clinically significant. Two, whether I should go the imaging route, whether I should go the microbiological route. So this is the thought process in my mind. In clinic, in reality, the patient was like, hey, don't investigate me again and again. My x-rays look like this only. You tell me two things that I need to do to understand whether all this is related to TB or not, and whether this is something to worry or it's just a part of my progression of my disease. And he was not very keen on getting the HRCT done. Cough since years, I'm not worried. You let me know why the sodium level is less, and will not get hospitalized, because I said that, okay, it's difficult to say. Very often we have one report. Based on that, we come to know the next step, how aggressive we have to go, whether I should bronch him, all the things that were in mind, but he's not willing for hospitalization. So then I said that, okay, at least get the sputum done. And the advantage of the sputum test, that one of our hospitals has a public-private partnership. So the gene experts happen for free of charge. So it's not very difficult to convince patients to get it done. I'm like, at least send that. We will have that stress out of our head once we know that the gene expert is negative. And because there is no other way, that's what I told the patient, as you rightly said, there is no other way to know whether this is an active TB infection or an old infection or a new bacterial infection that you have. We see chronic Pseudomonas colonization. Patients can come to us like that. So other than doing a sputum, there is no other way. So this comes to a very important practical point. What are the instructions that we give to our patients for sputum collection? So the sputum should be early morning. We have these designated Falcon tubes. What are they? They are leak proof. You airtight it after containing. There's no point giving a small bottle. We want the patient to cough out. So it is a wide mouth open bottle. You collect before blushing. So you get up in the morning. There is one entire chapter on how to collect sputum and instructions to give, but I'm just summarizing it in 4 or 5 lines. You wake up in the morning, you before brushing your teeth, you go to the window, take a few deep breaths, start coughing. We induce sputum with hyperneb, hypertonic saline. We now have it commercially available as 3% and 7% also. So you collect before the brushing, you take it the same day, spot sample we want, an early morning sample. If you're going and giving it to the lab immediately, then it is, you can give it at room temperature. And because of any reason, if you're giving it the next day, you have to refrigerate it. So if the person collects it on a Sunday, and we know that the labs are not going to be open on Monday, so that time you refrigerate it. Important point here is that if the patient has enough adequate sputum, we tell them to give a fresh sample. Very, very rarely in a hospital setup, or when, it's, of course, we can do bronchoscopy, but sometimes it's high risk. We want to try and just get the sputum, cost issue sometimes. So we induce the sputum and tell them to collect it over 24 hours and give the maximum early morning sputum. And those 24-hour sputum, we send for investigations. Right? So luck may have it, for this particular patient, his sputum, as you can see, this was a gene expert that we sent. So I had sent a routine culture, gene expert, and AFB culture. The AFB smear is negative. PCR test, that is the gene expert, MTB, Mycobacterium tuberculosis, detected very low, and it is rifampicin sensitive. Now, the issues actually, two things over here. The smear is negative. Had the smear been positive and I had got this report that the gene expert is also positive and AFB smear is also positive, I would have been confident that yes, this is an active infection. But we know that sputum gene expert is a PCR based. As you can see, it's a PCR based result. It, like any PCR based result, we can get a false positive, or even a dead bacteria can be available, can give rise to a false positive PCR report. So it's difficult whether how significant this is. And with the history that the patient is like, in the past, he also had tuberculosis. We, in an absence of a clinical setup, I don't know whether we will, pay heed to this report or not. And these are the practical challenges that we have. Now, false positive. Again, the second thing is, you'll see reports where MTB detected. It can be very low, medium, or high. So when it's high, medium, low, we understand the correlation is good. But in a very low gene expert, the correlation of the sensitivity and how accurate this is also questionable. So if there is not the right clinical setting, again, it's very difficult to bank on this report for taking clinical decisions. So now, expert can pick up dead bacilli, smear is negative, culture will take time to grow. Should we start TB treatment now, or should we do further investigation? So to which this was the exact conversation. And I think this is very important slide. Forget the science. This is what we deal with day in and day out in our clinics. This was the exact conversation with the patient, that with this first report, it is difficult to confirm whether the TB bacteria is active or because of old cavities and infections, etc. Because with that X-ray, it's difficult. We should do detailed imaging like HRCT thorax and SOS contrast, because if I get lymph nodes, if I get cavities, if I get tree in bud appearance, or any sign of active infection, indirect sign of active infection, it will be very important to correlate and even take the decision at this time. Now, yes, the culture can grow in some days, 1 month later, but till then, do we let this patient cough away, infect other patients if this is an active infection? Not really. We have to take a clinical decision very often here. And I'll remind you, this is a 70-year-old gentleman. So just giving AKT just like that, the risk of developing AKT-induced adverse drug reaction is also very high. So this conversation is very important with the patient. So this is what I told them. Better you go for the CT with a creatinine report and 4 hours fasting, so that if contrast is needed, it can be given. This is again a practical challenge in diagnosing TB. We send them for CTs, but if we have the proper channelization, we prepare the patients well, that you have to do a good breath hold. So make them practice a 10-second breath hold in the clinic. Have the conversation with the labs that this is what we are suspecting. So if required, you give contrast, because we miss so many things in a plain CT. If there is anything beyond the lung parenchyma, anything in the mediastinum, soft tissue shadows, lymph nodes, we miss them on a plain CT. So contrast is needed, and better to send them at a tell them to take an appointment at a time where they can be 4 hours fasting and do a creatinine report in advance, so that the labs and the diagnostic center can also decide to give the contrast if they think it is indicated. And the lab did call me once that this all would not happen if this was a IPD patient. We have these protocols set in our hospitals, but with an OPD patient, the patient lives in Mahim, is doing the CT at some center in Khar. But luckily the lab also called me, and I told them that this is what I am suspecting, and if you feel, if the radiologist at that time feels they need to give contrast, please go ahead. We have the patient coming in fasting and with a creatinine report. And this is what I have not kept the whole CT, but as you can see, these are the old cavities. This is what the patient meant, that no matter how many times you're going to do my CT, my X-ray, these lesions have been the same. These are cystic shadows, predominantly in the lower zone. And it would be great if this was a to and fro conversation, but I hope people have picked up that this is the trachea, this is the left lung, right lung, and as you can see, there is a cavity. Now, what is different between this cavity and these small little air-filled spaces? You can see one, the size, of course, it's a large cavity, and the border. It is a thick-walled cavity, which is again a sign of either tuberculosis, malignancy, or a cavitating lesion, but a sign that this is an active infection. He did not have mediastinal lymph nodes. Contrast was not required. And here we are a little more confident about the patient that, and with the patient that, okay, yes, these symptoms are related to active TB. And even though this is a gene expert report, we will pay attention to it and treat it accordingly. So the patient has been started on HRZE, that is the isoniazid, rifampicin, pyrazinamide, ethionamide, and B6 supplements. AFB culture is awaited. So I hope I was able to highlight with this case. Of course, I'm going to take a bit of theory part, a few slides more, but this is what happens in the clinic, that it is not so simple. Each patient is so unique. Of course, if this patient was RIF resistant, we would have a whole different discussion happening with the patient, the pre-treatment evaluation, and the reflex testing, which I'm going to come to next. Now, so drug-sensitive TB, still the treatment is simple. 2 HRZE, 3 HRE. There's no role of HR unless you have at the start proven that this is a INH and rifampicin sensitive TB drug. The duration can be extended based on clinical course. Generally, extrapulmonary tuberculosis like CNS, musculoskeletal, disseminated, drug-induced hepatitis if the patient develops, all intolerance to any drug, or discontinuation of one of the other drugs, we have to extend the duration of anti-tubercular treatment. Now the definitions from 5-7 years ago to now, the definitions have changed. What we mean by MDR-TB is a tuberculous bacteria where INH and rifampicin both are resistant. Pre-XDR is an MDR, that is INH, rifampicin, plus a fluoroquinolone. So your levofloxacin, moxifloxacin, etc. is resistance. XDR-TB, which is MDR, fluoroquinolones, or any of the group A drugs. Now I will come to that. Earlier we used to call XDR as MDR plus fluoroquinolone plus second line injectables. So amikacin, capreomycin, etc. But now we use any of the group A drugs, bedaquiline and linezolid. So this is what is updated when it comes to diagnosis of TB. Now LPA, so I have one slide summarizing all of these modalities, but again, not that you all need to remember this, but LPA report, what is more important is that we are moving more and more to, if we know that this is a smear positive patient, we are moving more and more to do LPA upfront because it gives us a lot of information. LPA along with mutations, one, we have a first line LPA. Gene expert will only make you know whether it is rifampicin resistance or not. But first line LPA will let us know whether it is rifampicin and isoniazid resistance or not. Secondly, second line LPA will make us understand whether there is a fluoroquinolone resistance or not, and a second line injectable resistance or not. And even furthermore, and there are some really good reference laboratories. That's why you will see most chest physician, and we having the luxury being in Mumbai. I mean, when you have this discussion somewhere else, these sort of labs are not available, but we have the Hinduja lab, which is a reference laboratories, a lot of research being done. They really spoon feed you. They give you the report, they give you the mutation, and they will give you the clinical implication also. So they will say INH mutation present, ethionamide cannot be given. CATG mutation present, high dose INH cannot be given. So this is the basis on which we formulate our anti-tuberculosis, and especially for MDR, anti-tuberculosis regimen. Again, fluoroquinolone resistance, Guy-Ray is 1, 2, 3. You cannot give levoflox. You can give high dose moxifloxacin, and Guy-Ray is A, 3B, C, 3C, 3D. Even high dose moxifloxacin cannot be useful. Why this is important is that 2 years ago, when we had an MDR, we just got a report of a gene expert, rifampicin resistant. Patients were started on a standard regimen. They were started on a 6 months injectable and other tablet regimen. But we used to later come to know, when we would get the cultures in 2 months, we would come to know that, oh, out of the 6 drugs that we are given, only 4 drugs have been working. And now we replace the 2 resistant drugs to a sensitive drugs from our kitty of the drugs that we have. This caused delay. This caused acquired resistance. This caused higher default rate because patients were on medication. A lot of these medications have a lot of side effects, and which is why we are moving to trying and diagnosing these patients with everything that we have upfront. So within 2 weeks of starting the TB treatment, we know whether an MDR patient also is resistant, whether the injectable is needed, whether fluoroquinolone can be given, whether high dose is needed, and so on and so forth. So, and just before I move to these things, no empirical AKT as far as possible. I'm not saying that we are not guilty where sometimes a patient has a pyrexia of unknown origin, nothing is coming positive. We've done autoimmune malignancy, PET is normal, and the only thing you have is a MAN2 positive. You will sometimes, we all are guilty of giving that empirical AKT, but no longer we would give an empirical AKT for a lung lesion where we have modalities to do a bronchoscopy and collect the cultures. If there are lymph nodes where I can take a FNAC or a biopsy, even if there are abdominal lymph nodes, we would even go up to the length of doing a laparoscopic biopsy. If there are mediastinal lymph nodes, we will do an endobronchial ultrasound guided biopsies of the lesions, but we will stretch ourselves to get the tissue because it is very, very important. And gone are the days where fine, there is TB, but now which TB, whether it is drug sensitive, whether it's MDR, and MDR, is it XDR? Because your whole treatment for the next 1 year of all these toxic medications is going to depend on the accuracy of your diagnosis. So as far as possible, no empirical AKT. Good sputum sample, BAL sample, EBIS, thoracoscopic sample, surgical sample, lymph nodes, whatever is needed. Moving away from injectable to now we have 2-3 new drugs. We have delaminid, bedaquiline, and proteonamide. We do not get them over the counter. Us in private practice also send these patients to a government accredited center. There are some private practitioners who've collaborated with the government and have these drugs available, but the procurement is free of charge, but it is only through the government. And we are moving away from injectable. Unfortunately, we've done that for 5 years. We've given injection for 6 months to our patient. The moment they were MDR, we would give them kanamycin for 6 months. Patients have taken it, lost their hearing at times, but there was no other option. But now that we have options, we have moved to oral tablets. And these are the new 3 new drugs. Although bedaquiline, delaminid is available in the program right now, proteomanid is the BPAL trial was going on. That's when we had it in Mumbai, but it's stopped, but it's going to come in our regimen hopefully soon. And streptomycin is reserved as a replacement drug when amikacin is not tolerated. So these are a few things that are different. Okay. Okay. There is some issue with my slides. I don't know why it's not moving. So again, you all don't need to get into all this, but H monoresistance, we know that if when we do LPA and we realize that rifampicin is sensitive, but INH is resistant, sit with levoflox and continue it for 6 months. Now, this is the slide where I want your attention again, and it is very, very relevant. And this is one of the major challenges we have in our diagnosis, that like our patient, we have sent. I'm sorry, this is a wrong, it's not NTM, it's TB culture. That's how the report will show. The specimen, whatever it is, whether it's bile, sputum. Now here you can see that smear is positive. Yeah, here you can see that the smear is positive and culture is awaited. Now, this is very important to tell to our patients, because people do surgical procedures, we've sent it for cultures, but nobody has followed that up later. So the way it goes is that the first report comes in 3 days, the next report comes in 10 days, the next report comes in 3 weeks and 6 weeks. So we have to remind this to our patient that once you've sent the sample for AFB culture, the best way is to tell the patient to get the bill. That's the only way I found, because it's so difficult to explain this to the patient that some report sent today will come after 6 weeks. Wo 2 mahine baad aayega. But TB culture bracket MGIT bracket backtech is the way certain lab use different language. We've had mistakes in the past where we've written TB culture and the labs have processed a routine culture, which is an aerobic culture, which comes in 48 hours. So this is a very important report, because I'm going to discuss the advancement of TB diagnosis, which, surpass this challenge, but the gold standard is still the culture with the backtech medium and the sensitivity on that. Now, again, like my very of the complicated slides, you all don't need to remember this, but I want you all to just identify a couple of things, that when this is in the program, when the patient undergoes a gene expert, the CB-NAT, if patient is rifampicin sensitive, like our patient, they will just on its own, the lab at the back end, without us saying anything. If it's a government accredited lab, will do a line probe assay. They will just see whether INH is sensitive or not. If the INH is sensitive, we will anyways continue the treatment that we do. If there is INH resistance, they will then, what I showed you, they replace the isoniazid with the fluoroquinolone, and that's how the treatment changes. 6 to 9 months duration, nothing really different. Instead of 1 tablet, second tablet goes. Now, if there is a rifampicin resistance, the lab is now directed to do a line probe assay of first and second line, in which we'll come to know about INH, injectable, and fluoroquinolone and the mutations. And then when the culture, LSDST, where the liquid culture comes positive, they will test it for these things: pyrazinamide, bedaquiline, clofazimine, moxifloxacin, linezolid, delaminate. And this happens reflexly in each lab. So that's why more and more of us are also using the government accredited labs to send. And all of these, most in Mumbai, a lot of this burden anyways goes to Hinduja. The only challenge we have is that the time taken for the report to come back is really still high, practically speaking, but this all is done automatically. So the patient doesn't have to pay, because if we are to do all this in a private setup with the patient paying directly, a CB-NAT costs around 2,200. Line probe assay will also cost around 2,000. 2,200 for the second line listening, 1,500 for a culture. So just the specimen for TB related diagnostic goes up to about 10-12,000. Sorry. Then when the culture comes positive, the sensitivity test ranges from 12,000 to 15,000, a 14 drug DST. So that's how costly it is. Right, sorry. So in a resource limited setting, it's okay to utilize these labs and just keep a close follow-up with the reflex labs. Now, this is the other diagnostic dilemma that we have: expert MDR, XDR, TrueNat, LPA, solid culture, liquid culture. Solid culture is what I think a lot of y'all also would have studied during your MBBS, and we used to study the LJ medium, which takes really 2.5 months. This becomes faster when we have the BACTEC liquid culture. Expert is the report that I showed you. It will let you know about rifampicin, where one, whether TB is positive or not, two, whether rifampicin resistance is there or not. Now we have an expert ultra, expert MDR, XDR, where you within 24 hours, you will come to know whether rifampicin resistance, second line injectable, ethionamide and fluoroquinolone resistance will come to know. This is a point of care test, meaning only one, you take the sample. There are not too many steps. You take the sample, put in the cartridge into the device, and you get the report in 2 hours. Line probe assay, what I told you, where you get first line and second line also. And liquid culture, once the bacteria grows on this culture, then we do the sensitivity test. So this is a back and forth between the doctor, patient, and the lab. At least 4 times that happens through the patient's diagnostic journey. Now, other options, because you can imagine, patients, one, following up, two, realizing that, okay, they have to pay again and again. So the research has been towards last 2-3 years about if we can do one test where you come to know whether it's positive or not, and whether you come to know whether it's a completely sensitive strain or not. So as genetics have evolved, you have something like whole genome sequencing. This is the new kid on the block, where once you have a smear positive sample, you come to know whether it's positive, and whether you have 18 antibiotics. All the antibiotics based on genetic testing, you can come to know within 12 days. And the cost of this is around 6,000. We are not yet moved completely to this, because the 100% correlation, this, like I said, gold standard as of today, as we speak, is still the BACTEC culture and the sensitivity of that. But yes, if it is a rifampicin resistance, it will give us some idea quickly while we wait for the culture, rather than going to step 1, gene expert, then LPA, then culture, then the DST. This would give us some idea to formulate a regimen in the first 12 to 15 days only. Culture DST, 12 to 14 antibiotics, 3 to 6 weeks turnaround time. CB NAT, only rifampicin we come to know, but we get the report in 24 hours. And this is a good sort of screening thing for MDR. And LPA, targeted mutation for first and second line, 4 to 5 days. So that's with that intention, the whole genome sequencing is looking promising, and we may move to it if it comes in the program, nothing like it. Now, the drugs that I was talking about, the groups of drugs have changed. We do not need to, I don't expect the audience to, remember and formulate the regimen, but it is very important to understand that how important bedaquiline and delaminate have become in the regimen of MDR treatment. It is now a group A drug, fluoroquinolone, and which the take home should be that you will never see, very rarely you'll see a pulmonologist or someone who deals with TB regularly, TB patients, giving a fluoroquinolone as a routine prescription for LRTI. Because if somebody has concomitant tuberculosis, giving a 5-day course of levofloxacin can also make the patient develop resistance, and unknowingly we are contributing to the MDR burden. And fluoroquinolone is a very important drug when it comes to our regimen for MDR patients. So fluoroquinolone, bedaquiline, linezolid. One of the group B drugs, that is clofazimine, cycloserine, terizidone. Group C drugs, that is ethambutol, delaminate, pyrazinamide, imipenem, celestino, meropenem. This drug is a very important thing for salvage regimen. When nothing else is working, we have put PIC lines, and this initiative and trial was by the MSF at Chembur. They have their center, where we would also refer to a patient that all drugs are resistant, and they would formulate where they would put a PIC line into the patient, and the patient was taking IV imipenem, celestine twice a day for 6 months. Amikacin, streptomycin, reserve drug, ethionamide, prothionamide, and PAS. PAS is either as a granule or, tablet. But the tablet patients have to take almost 12 to 13 tablets per day. So coming back to this, again, no need to remember, we discussed up till here in the past. After we have the results of these LPAs, etc., based on the regimen, whether short oral bedaquiline based regimen is allowed, longer regimen, or salvage regimen is needed. This is what we decide. Sorry. Now, so with this, I was just summarizing, identifying patients is important. Symptoms are such slow growing that sometimes initial X-ray, how soon is too soon? People come with us, with 1 week of cough and X-ray, that's normal, not necessary that it will show up in 1 week. So initial X-rays can be normal. Once TB, can always get TB. Remember the diabetes burden. Other drugs and treatment causing reactivation. We have our chemotherapy patients, steroid patient, rheumatoid, the tofacitinibs, rituximab. We have these patients for other reason, they are on immunosuppressants, anti-TNF drugs, methotrexate, steroids. They can have reactivation of TB. The so-called vaccine is only protects you for till 5 years of age, the BCG, and that too against only disseminated and CNS TB. The bacteria is evolving, MDR, pre-XDR, XDR, TDR strain, and developing resistance to more and more drugs as either patients or doctors make mistake. So the aim of treatment that it should be adequate, tolerable, minimum duration. That's why you saw in that algorithm, the 6-month regimen, short all oral regimen is also an option. We want acceptable side effects. Sputum culture conversion. Every month the patient is, the MDR TB patient is sent, we send TB cultures. Relapse-free survival we want, and contact tracing of family members. This is very, very important. Recently, and it's easy to miss, but if all of us, if the specialist forgets it, and the family doctor reminds that, oh, someone is sputum positive in your family, why don't the rest of you all get a X-ray done? Otherwise, this is a cycle that we see, that the first index patient is unwell, and this is not like COVID, right? Where every 4 days, 5 days, the patient will develop, the next family member will get infected. After 3 months, the second family member is infected. After 3 months, the third family members come with some symptom. So it's better if you across immediately get an X-ray or a clinical evaluation, whether there are any lymph nodes or not, of the family members as well. And it is important to prevent MDR TB, treat DSTB adequately. Treatment decision and outcomes depend on the sample and the microbiological evaluation of the TB bacteria. With newer drugs and timely accurate treatment, duration of treatment is reduced. We need more information beyond sputum, AFB smear, and gene expert, LPAs, and hopefully in the future, pyrosequencing and whole genome sequencing will be useful. Formulate an adequate regimen, counsel the patient, identify ADRs on time, and use drug replacement sequence and target follow-up. 2 slides, I was talking to other pulmonologists, who are very actively in the field of TB, and I told them that I'm doing a talk with general practitioners, and what are the few things you will want me to, highlight, which beyond the science in today's practical world work is important. So they said that it is so important for the family physicians to counsel the patient, because every time in the lab, AFB is positive or gene expert is positive, centrally the lab is supposed to notify. Even doctors are supposed to notify the labs, but labs also supposed to notify the patient. So automatically that data goes into the system. Patients may get a call, nothing to worry about. It's not that they're going to come to your house and, isolate you in that way. They just want to know that you've been directed correctly or not, whether you're taking treatment or not, if you need financial assistance, whether government-based regimen free of cost can be given or not. The ID is specific to each patient. They will take Aadhaar card number. They ask for bank accounts. So I counsel each and every patient that that is a choice that you have. These are the things that government have made available for our patients. So at the end of the treatment, you will get reimbursed with some amount of money. Some amount of money goes to the doctor or the staff who is notifying the patient to the government also. So these are some incentives that the government have given. And reimbursement, and of course, the treatment is free of choice, free of cost, reimbursement for doctors, and prevention of treatment. There are talks of gastric aspirates in adults when you can't, when you don't have bronchoscopy available. CB-NAT on follow-up cultures also they are doing. Government labs free of cost, reflex testing, public-private schemes. The staff can be utilized, they can be incentivized for notification and inform about the Aadhaar card. So with this, I would end my end of the conversation, and I'll be happy to take questions here on.
Thank you, Dr. Sonam. There are questions. How many millimeter size of retroperitoneal lymph nodes can be said as diagnostic of abdominal COX or highly suspicious of?
Right. So normally abdominal and mediastinal more than 1 to 1.5 size is, the lymph nodes are significant, pathological, I would say. And whether it is tuberculosis or not will be a histopathological and microbiological diagnosis. So we keep telling our surgeons also that whenever you're removing a lymph node, normally is you remove and put it in formalin and send for histopath, but we want to send them for histopath and TB related. So that sample has to be collected in normal saline. Histopath sample has to be collected in formalin, and they have to be processed in one in pathology department and one in microbiology department. So size wise 1.5 onwards, but whether diagnostic of TB depends on pathology and microbiology.
Thank you. Now, one case you mentioned of hyponatremia, when doctor is asking, fever was not documented, but hyponatremia was diagnosed. What is the significance of hyponatremia here?
So here I attributed, because he had been worked up, so just a chronic infection being the cause of hyponatremia, that's all we could get. Other than that, there was no other cause that we also found.
Thank you. Sputum samples collected at different times should be sent collectively in a single container?
No. So when you go for a gene expert, they'll give you 2 containers, one spot sample and one early morning sample.
Is
so generally 2 samples.
Is tuberculin 2U same for all ages children in MANTU test?
Yes, in India, we have moved to, from a 10 TU, we moved to a 2 TU because we would get a lot of false positive. So it is the same.
How to confirm diagnosis of TB spine?
So TB spine, same thing. If there is a collection, paraspinal collection, we can either do, depending on the size, location, etc., we can do a CT guided fluid aspiration, paraspinal abscess collection. And if it is just the spine, then sometimes we have to take an operative sample, including our orthopedician colleagues. And again, like any diagnostic importance for tuberculosis, samples have to be collected in 2 containers, one for histopath, formalin, and one in normal saline for cultures.
Now, ma'am, if imaging shows a vertebra eaten away, then on imaging alone, we can't differentiate between tuberculosis and malignancy, no?
No, it's very difficult sometimes. There are a few signs and symptoms based on, so if there is a malignancy and there is some other lesion elsewhere, that is one thing. Paraspinal region getting affected because that is the blood supply to it, right? The disc above and below. That is very classical of tubercular involvement. But in today's day and time, if you have access, you would not just say that this is TB or even if it is malignancy, you will need tissue. So there are few radiological signs, what is collapse, whether it is a central onwards necrosis or disc above and below, which will give us some idea, but we would still need a tissue diagnosis.
What is the duration of AKT for pot spine?
I had mentioned in one of the slides, CNS tuberculosis, musculoskeletal tuberculosis, 18 months we give, even if it is a rifampicin sensitive TB. 1.5 years.
Thank you.
Those are the.
One doctor is asking, empirical means give all drugs or only 2 drugs or 1 drug?
Just a second. 10 minutes. Online. Sorry. Yeah, so when I say empirical means that it is only suspicion-based TB treatment we have started. We have not had a 100% diagnosis of TB, and even if it is empirical TB, the treatment is never 1 drug, 2 drug. So, I mean, this is beyond the scope of this, the rationale of why we need 4 drugs. Why even in MDR we are giving 5 drugs, 6 drugs together, because that's how the bacteria is. The bacteria, if you give only 1 drug, out of 100, 6 of them will have a natural resistance to it. And then after 1 month, 6 of them will become 600 bacteria. And now this whole population of bacteria is resistant to 1 drug. That's why you have to give 2, 3, 4 drugs together, so that if 1 bacteria has a natural resistance to rifampicin, INH, which is a bactericidal, will kill the bacteria. So that's the idea, never 1 or 2 drugs. The only time we give 1 drug is when we are treating latent TB infection. Latent TB means, like we discussed, MAN2 IGRA is positive. Patient has had TB in the past. We know it's not active TB, but because of, say, rheumatoid arthritis, we are now putting him on methotrexate, the biologics for rheumatic disease, which are immunosuppressants or anti-TNF drugs, etanercept. Then we have to choose to treat these latent infection. That time you will give INH 1 drug for 6 months, or rifampicin and INH combination for 3 months. There are regimen of treating latent TB infection. In India, we don't treat all latent TB infections, only when they are undergoing a specific immunosuppressants. Commonly, when our rheumatology colleagues send us these patients, we treat the latent TB infection. And otherwise, even if empirical, all drugs together.
Dr. Mukesh Patel is complimenting you. Excellent webinar.
Thank you.
Then the next question is, how do we at our level suspect ocular TB and then refer appropriately?
Right. So normally uveitis like symptoms, non-specific, and ocular TB is one of the things where even I would go send to an ophthalmologist, tell them that you do a complete evaluation, dilate and see. Recurrent uveitis, very often it correlates, your HLA-B27 positive uveitis. Of course, anterior, posterior, there are way to differentiate, but I would involve an ophthalmologist early, and they would tell me, oh, this is looking like tuberculosis, because it's very difficult to sample also. So that time we rely on, say, IGRA positive, clinical condition is like that, and then we, start the treatment.
4/7 HRE means, how is the regimen?
So when I said 2 HRZE for 2 months, and then after the intensive phase is over, the pyrazinamide goes away, and only isoniazid, rifampicin, and ethambutol continues for the next 6 months. So if it's a 6 months regimen, 2 months is 4 drugs HRZE, and the remaining 4 months is HRE 3 drugs.
And in a 9-month treatment, 2 months is with rifampicin and 7 months is without that.
No. In 9-month treatment, the continuation phase is extended. So 2 months HRZE with rifampicin, and the remaining 7 months is HRE without pyrazinamide.
Yeah, that is what I was saying. Yeah.
Rifampicin is a very important drug.
Can we use roxithromycin in a URTI, or is it also to be reserved like quinolone for MDR TBs?
So we don't use generally roxithromycin, or we are not even testing for this thing. In general, there is no 100% data on this. So if we have alternate of other drugs, I would avoid fluoroquinolone in general, but this is not a reserved drug for MDR as of now. There were discussion of gatifloxacin also when it came. Generally, we would be a little cautious, but as of now in the MDR regimen, we are not using it.
There is a specific case history. A patient diagnosed as spine TB started AKT, but fever continued for months. Then patient goes in septicemia. So what is the possibility to cause septicemia in this case? And why no response to AKT? And connected question, after how many days of starting treatment, we can think AKT TB will respond?
One, if diagnosed correctly, when you say diagnosed TB spine, I hope that we have microbiological diagnosis and we have the microbiology where it's rifampicin sensitive, and the AKT that we are giving, the first step is diagnose microbiologically or not. Second thing, AKT we are giving is appropriate or not. So if it's MDR and you're giving a HRZE, like a drug sensitive, will not respond. We also see that rifampicin and INH level very often, even if the drug is sensitive to the bacteria is sensitive to these drugs, the drug level in the body does not reach appropriately because of some absorption issue. So then we do rifampicin and INH level in the blood. Only Hinduja does that actually. And we have to then give higher dose of rifampicin and INH also to the patient. So there are multiple reasons why this can happen. Septicemia, then whether along with TB, you also had a bacterial osteomyelitis or not, and that is causing the septicemia. And if the patient is not responding to this, the TB will become disseminated TB. Very rarely we see septicemia. So I think we'll need to evaluate this from that angle. Response, I tell patients that your fever and all should respond in 1 to 2 weeks. The cough, breathlessness, 3 weeks. But you have to go back to feeling good at 80% of what you were by the end of intensive phase. It should not take more than that.
How to diagnose primary complex in a child below 5 years?
So normally this is radiological diagnosis that they do, and gastric lavage we send whether it's active or not, because they are not very often able to bring out sputum. So gastric lavage is, and gene expert, all the tests that I said, gastric lavage subjected to all the microbiological examination.
In a pulmonary TB, after how many days of starting AKT should we repeat an X-ray to see improvement?
As per the guidelines, end of intensive phase, but practically after 1 month, we tell them to repeat. And this is how we counsel the patient that the first 2 months, a little bit investigations will be extra, but your follow-ups will be more monthly follow-ups. But by the end of intensive phase, at the end of 2 months, we've had all the culture reports. We know that we are going on the right track and we've documented good treatment response. So 1 month, guidelines wise, end of 2 months.
Now, ma'am, you mentioned IGRA once, and I recall WHO few years ago saying that blood tests for TB are not to be done. So there's a question, should we go for the gold test normally when we deal with tuberculosis or not in all cases?
Yeah, so I think the very rightly what you're remembering is the IgM test, which was called back by the WHO. So like we have in our typhoid, right, where we have IgMs. Similarly for TB, IgMs, there was a panel earlier, and people were receiving AKT based on that. That is completely called off. At least since 2014, when I was a resident, I think that call was around 2012 or 11. Sorry, 11, yeah. And we no longer do that, have that, etc. IGRA, what I mean is basically a blood test, like Mantoux test. We are doing it only, the case that I described, there is a fever, everything is there, or sometimes you can't sample, a lymph node is in a position, there is some uptake, we don't know what it is, and IGRA is positive, and that's the only thing that is giving us some sort of direction. Very, very rare cases that we would use it. And the only actual place where I'll use it is when for treatment of latent TB infection, where I need to, give LTBI treatment for a patient going on rituximab or other biologics, and our rheumat colleagues want to screen for that before starting etanercept and other injections. Then only I will do an IGRA.
Yeah, because we do it very often when students going to US for further studies.
So that is a protocol mandated by their
Their
governments,
government, yeah.
and they will treat it. So what they do, because they have such low levels of TB, even a latent infection they want to treat, because for if we start treating latent infection here, I think all of us will be on treatment. But they treat latent infection there, and students tell us that they treat it as if it's a fresh infection, because the prevalence of TB is very less over there.
What should be the size and number of neck lymph nodes to be significant for TB? Dr. Pallavi, I think size and number you cannot diagnose TB. You have to do a biopsy.
Correct. FNAC or biopsy.
Okay. Can a family physician use second line therapy of TB?
I wouldn't recommend. What I would tell, firstly, so we don't have access to second line drugs. Even a chest physician sitting in the private clinic will not start treating MDR TB. For once, we have to send them to the government regimen, where the regimen is made by a DOTS officer who is trained to do that, because things are changing so rapidly. 5 years ago, this PPT would be completely different, and maybe in 2 years, this PPT will be completely different. So one, if you're updated in close correlation, what I tell patient is to stay in touch with their family doctors for regular visits of development of ADR, adverse drug reaction. So if there is, hearing loss, peripheral neuropathy, regular doing your CBC, LFT, RFT, and going to your family doctor, these things can be picked up earlier. This is what patients do with us in our private practice also. But treating completely, we don't have access to these drugs, and I wouldn't recommend.
Any role of bedaquiline as first line therapy?
Not for a rifampicin sensitive TB, for a MDR rifampicin resistant TB, it is one of the first line drugs now, whenever possible.
Some children after giving BCG develop enlarged axillary lymph nodes. Do they have to be treated?
So if it is a hyperimmune response, with time it goes. Sometimes steroids also work, but if there are guidelines that if it is, you prove that there is necrosis, you have to then give AKT. If there is necrosis, caseation, lymph node enlargement, not going after the initial this thing, you sometimes have to, very rarely.
Any recommendation for chemoprophylaxis for contacts?
So recommendation for a rifampicin sensitive TB, children less than 6 years of age, we have to give them INH prophylaxis. So I tell them either you get the child to us in our clinic or take them to the pediatrician. If somebody in the family has a sputum positive TB, now this is also very important. Only a CNS TB and lungs are normal, I would not want to treat the contacts. Only lymph nodes and nothing in the lungs, I will not want to treat the contacts. But if it's a sputum positive pulmonary TB, 6 years and below children, we would treat with INH prophylaxis.
You said once gastric lavage. Why not bronchial lavage?
Bronchial lavage is, and especially for children, is more invasive. It's under anesthesia. You have to give them complete sedation, sometimes general anesthesia. So the cost, the burden for the patient. So, and they are known to keep swallowing their secretions. So, even when you'll see that the mother will say, "Ke vomit hua and sirf cough tha." So that's why you have studies where there is good correlation, at least at the start, to send a gastric lavage for gene expert and culture. That's the only reason.
Within how many days we expect weight gain in patients once
I
we
tell
start
them,
AKT?
don't expect weight gain for at least 1 month. Again, I'm not aware, I'm not that well read if there are studies evaluating the pattern of weight gain, but if I'm speaking with experience, by the intensive phase, getting over stabilization and maybe 1 to 2 kgs, and then when they come on follow up, and that's why evaluating for nutritional deficiencies is important, and supplementing with protein powders. So maybe 1.5 2 months, I would.
I will add my one point here. Please do not give tonics to TB patients, because that may give you a false sense of security by weight gain.
That too.
You may just give good diet and drugs. And I have seen a lot of files, 6 months TB treatment, not even one weight captured. So make sure you have a weight captured at least once a month.
Absolutely. Weight is a part of every, like, the name, age, date, and weight capture. I think it should be standard protocol.
Now, doctor is asking, in 1 year child, GP can start treatment, no TB treatment.
Yeah, if it's a drug sensitive treatment and you're confident and updated with the knowledge, there is no harm in standing as per weight. So there are a few things, the weight criteria are different. So 15 ethambutol and pyrazinamide higher dose, we can go up to 25 milligram per kg in children. So if you are comfortable with that, there is no issue. Just make sure that it is drug sensitive TB.
And you have a definitive diagnosis. Just on symptoms of fever and recurrent cold, we cannot give TB treatment.
Yes.
If sputum gets aspirated by pulmonary cox during its initial phase of treatment, does that patient get GI-TB along with pulmonary TB on treatment?
No, no evidence of that.
Will X-ray revert to normal after treatment?
Yeah, so if we've seen pleural effusions and pulmonary TB, if already when you started the treatment, there are cavitating and fibrosing lesions, then there may be some lesions that stay at the end of the treatment. So it will really depend on how effectively and when have you started the treatment. If it's started in an advanced stage, we do see some fibrosis because we know that TB is, it heals with fibrosis. So we, end of the treatment, also take an X-ray just to document. And I tell the patients that you keep these X-ray. 5 years later, also for whatever reason you do an X-ray, daag reh gaya, again everybody gets worked up, and it's very important to understand reactivation also when you are able to compare it with old X-rays.
Yeah, this was very important because earlier Gulf countries would reject visa to anyone with an old scar also. Till we started giving clarification of that.
Yes, we also get many references of just clarification that this is not infective to others. Then I think still some countries and agencies reject them for no, and it's at their discretion. Even if we've written the item, it is done.
Lastly, you mentioned in chemoprophylaxis. So if there are no sputum positive, then no need to give chemoprophylaxis, no?
No, no.
Thank you very much, doctor. There are no words to thank you. And I am sure people are already demanding more lectures from you. So maybe in 6 to 8 weeks time, we'll trouble you once again with some good topic for GPs.
Sure.
Thank you very much.
Thank you.
Yeah. Thank you.